Move to our last presentation by Dr. Gabriele Gasparini from Italy. He will talk to us about the provisional versus double stenting and bifurcation lesion.
So good afternoon, everybody. So the question is still open. Let's see if the last presentation will provide you the right answer. I hope that you will not be disappointed. So first of all, we can start once again to consider what's the definition of coronary bifurcation. From ABC, it's quite pragmatic. It's a coronary artery narrowing occurring adjacent to and or involving the originating a significant side branch. So what does a significant side branch mean? A significant side branch is a branch that operator does not want to lose in the global context of a particular patient. So, but this definition is quite general. So this definition does not provide us the right answer. So despite several randomized trials, as we already seen in the previous presentation, the optimal PCI technique for bifurcation still remains a matter of debate. And this is the right session to debate it. What we know? We know the definition of the true bifurcation thanks to Medina classification, but the true bifurcation, we know that the true bifurcation have been associated with higher all-cause mortality and MACE. So we have to deal with this kind of bifurcation in the right way. But accordingly to the Medina classification, we know that in case of simple lesion, maybe the provisional stenting has been recommended as a default strategy for most bifurcation lesion. But in complex lesions, such as true bifurcation lesion, emerging in data support the DK crash as a default two-stent strategy. But the problem is that the Medina classification does not provide sufficient information about the real complexity of the anatomy of the bifurcation. It's just a question of dichotomy, 1 or 0. So, as Mirvat pointed out, main aspect of anatomic complexity of bifurcation should keep in mind, so such as distribution of atherosclerosis, spatial resolution between the branches defined by angles, and the tapering nature of the side branch, and difference between the diameter of the side branch and the ostium of the side branch. And finally, last but not least, asymmetrical geometrical reduction of the vessel at the bifurcation side. So as this factor vary between the patients, so it's up to the operator to assess which side branch need to be preserved and choose the right decision and the right technique. So several parameters such as larger side branch, long lesion, wide bifurcation angle, high risk of hemodynamic compromission after reduction of flow in the side branch have been introduced. But how large is larger? How long is longer? What are the accurate predictors of acute side branch closure? We know from several randomized trials that it seems that provisional stent provides better outcome, but it's too early to conclude that provisional stenting can be considered a final solution. It could be, but not necessarily the final or the right one, because the majority of the previous trials were conducted using the Medina classification, so this could be a limit. So for this reason, we already have seen the definition criteria, so I can skip it and go ahead. So thanks to using the definition criteria, now we have some criteria to identify a real complex bifurcation. And accordingly to the definition criteria, this is the suggested approach to the bifurcation lesion. Start with the provisional, then evaluate if we are dealing with a left main, non-left main bifurcation. Consider the entity of the stenosis of the side branch and the length of the lesion, then check for minor criteria. If you should add two of any of the minor criteria, you have to deal with a complex bifurcation where a two-stent strategy could be better. But definition trial has some limitation. First of all, the incidence of myocardial infarction peaks at the time of the index procedure. This could be related to a suboptimal one-stent strategy due to insufficient side branch dilatation or restrictive use of crossover stenting. Then a sharp increase in the rates of target vessel revascularization at 12 months. So it's not clear if this angiography were driven by clinical events or not. And then lack of functional test at the follow-up. Side branch lesions are usually not functionally significant following main vessel stenting. So quantitative angiography is not reliable in assessing this severity. So we should also to keep in mind this limitation. Differently, if we discuss about left main disease, accordingly to the definition criteria, we know perfectly what is a complex left main bifurcation disease. And also, we have different results from the literature. The decay crash suggested to use the decay crash, so an upfront to stent strategy, while the ABC man suggested to use a more conservative provisional stenting strategy. So the question is still open. What to do in complex, in this case, left main bifurcation? I think that at the end of the day, we should be honest and we should admit that we are talking about philosophy. We have two different philosophies. If you are more close to the Asian bifurcation club philosophy, you can go on with a two-stent strategy. If you are more close to the European bifurcation philosophy, you should consider provisional stent as a first intention treatment. But in the left main, we have some added information that can arise from imaging evaluation. So in left main, we should use imaging and IVUS to evaluate not only severity of the lesion, but also distribution of the plaque that can guide us in terms of the right strategy to use. So in all the bifurcation, in all left main bifurcation lesion, in my practice, I perform both pullbacks to check LAD and the circ in order to have all the information that I need before planning my strategy. So, information that can guide me in choosing provisional stenting are the following. If I have to stent lead main to LAD, it's in case of small circ or in case of no disease of the circ, less than 50% of plaque burden, or lesion in the ostial circ less than 5 millimeters, and wide angle between LAD and the circ. But the main important aspect is the IVUS run. So if I have no significant ostial circ disease by IVUS, it means MLI more than 3.5 millimeters square and plaque burden less than 50%. In the different situation, a left main to the circ, if the LAD ostium is free from disease or mildly affected by IVUS, and the circ with significant lesion in dominant or more than 2.5 millimeter vessel. Differently, I prefer to use a two-stent techniques in case in which we have a not so small circ with any of the following. Significant and long, it means more than 5 millimeter lesion in ostial circ, a true bifurcation lesion, or complex lesion in ostial circ related to the plaque composition, a narrow angle between LAD and the circ, and a significant ostial circ disease by IVUS with an area less than 3.5 millimeters square and plaque burden more than 50. And of course, in case of poor result after previous provisional stenting, in terms of stenosis more than 75% or reduced flow less than 3 TIMI flow, residual dissection or FFR less than 0.8 or IFR less than 0.9. But finally, I have the right answer for you because even the previous presentation point out that question is still debatable. We have the right answer, and it's a sort of an eternal dilemma, eternal saga, choice between one or two stent strategy. But I would like to point out what the author of the European Bifurcation Club consensus on bifurcation lesion treatment. They underline that the provisional strategy is a treatment philosophy rather than a technique that meets the main objective to...
Can we have
Okay,
30 seconds more?
Anyway, to reconstruct the bifurcation architecture using a single stent strategy. But my final message are this one. The philosophy of making complex matters simple, that has been supported by several clinical trials, should not be translated into a quick and dirty strategy. If we decided to go on with a provisional strategy, we should do it in the right way, following all the steps that have been already presented in the previous presentation. Simple is better for most bifurcation lesions, but the aim should not be saving time and should not be a consequence of a lack of technical skills. No pain, no gain philosophy should be applied to all complex bifurcation, independently of which technique we decided to use. And always end with final pot, both provisional and two-stent strategy. Thanks very much for your attention.
Thank you very much, Dr. Gabriele. Dr. Kenny in Mount Sinai already scrubbed and ready for live transmission, so I'm going to allow one question before we conclude. Dr. Saleh.
Thank you very much, Dr. Gabriele. It was an amazing overview. And, my question is, would intravascular imaging help decide between one stent and a two-stent strategy in a non-left main lesion?
Sorry?
Intravascular imaging, would it help in deciding?
Yeah, you are right. In my opinion, I always use IVUS when I have to treat a bifurcation lesion. But I think that all of us can agree that in left main, it's mandatory. So if you have the opportunity to use imaging and IVUS to evaluate the plaque distribution in all bifurcation, use it. Because IVUS or imaging can provide you a lot of information that are angiographically missing. So the plaque distribution, the plaque composition, the calcium burden, that can help you in guide in the choice of the right technique. But then in the left main, I think that it's mandatory because also we have some, cutoff to consider, especially for the ostium of the circ, that also can guide us in the choice between one stent or two stent strategy.
Great. We cannot refuse Dr. Hussein, but this is, promise, the last question. Go ahead, please.
Actually, it's not. Why it's not? The mic, please? Yes. Or it's working?
Yeah, it's working.
Actually, this session made me confused because what I got from this session is that first, incomplete revascularization is okay and is better than complete revascularization in patients with bifurcation lesions. Again, leaving a vessel which is diseased is better than treating it. Doing PCI or just PUBA is better than stenting, even though we know that PUBA is associated with 50% restenosis. We are looking at studies with IVUS or OCT of less than 40%. Again, we are referring to a study which is ABC main, which uses kilot, which is the worst technique in bifurcation stenting. So actually all the three presenters, they presented different or conflicting evidence. So what's really the truth? Shall we really incompletely revascularize patients or completely revascularize them? Because all the evidence goes with incomplete revascularization from the studies you've presented, which does not make sense based on the previous or the cabbage trials. Thank you.
You want to handle that, or shall I? You go ahead.
So the question is not to provide a complete or incomplete revascularization with to the patient because we are treating the bifurcation. The question is treat the bifurcation in the best way and the most effective as possible. So we learn from this session and from several different data arising from the literature, there are no clear evidence which is the best strategy. We have criteria, the definition criteria that can help us to identify a complex bifurcation. But after that, we don't have enough, a clear evidence that the best way to treat a complex bifurcation is with the two-stent or with the single-stent strategy. So we have several different options, but I think that if I have to treat with the two-stent strategy, I prefer to use the decay crash. This is my favorite two-stent strategy in all the bifurcation, not only in left main. But while possible, I prefer to follow the European Bifurcation Club philosophy that suggests to use provisional strategy. And maybe we can use also some drug-eluting balloon, and in the next future, we will have more evidence about their use in this subset.
Okay, thank you very much all. It's a great topic again, and we cannot finish this topic and with a great panelist, but we have to move on to New York with the live transmission there. Dr. Abdullah Shihab will run the next session.